All right. Well, why don't we go ahead and get started? First and foremost, I want to welcome you and thank you for joining the webinar. We're obviously focusing tonight on Barrett's esophagus, and we're going to go through sort of the continuum from where it starts and how it ends up in esophageal adenocarcinoma. But first and foremost, just want to sort of introduce ourselves. I'm obviously Sri Komanduri. I am the sort of national, international expert on Barrett's from Northwestern University. My partner in crime tonight is John Lipham. He was the only one actually available from the surgical side. So bear with us. We're each going to babble for about 20 minutes here, and we'll leave hopefully 15 or 20 minutes at the end for questions. Feel free to put your questions as you think of them into the Q&A, and we'll try to get to them at the very end. So anyway, welcome and thank you again for joining. My talk is going to be really mainly focused on what's leading to Barrett's. And obvious to everyone on this webinar tonight, it's obviously reflux. But I think there's a lot of misunderstanding, maybe even confusion in regards to really what causes reflux, what is leading to reflux, and understanding the barrier that prevents reflux. So I'm going to start with the basics and really just kind of give you a refresher on really what constitutes the barrier to reflux, and ultimately what our options are to restore that barrier. So first and foremost, some disclosures. I am a consultant for a couple of the companies here that I'll be talking about tonight. But the question that I always pose to everybody is, do we really understand the barrier? Even though we may be experts in the field, we do this day in and day out. I think throughout history, there's been a lot of dogma that's been perpetuated in regards to really what constitutes that barrier. So your answer could be, yes, I understand it. No, I don't understand it. Or even I pretend to understand it. I think my answer to it, I think as a whole, is I think we don't act like we understand it. At least we haven't acted like we understood it for the last 20 to 30 years. And so, as I said, my objective really is to review or re-review the GERD barrier. And I'm going to focus quite a bit on what I'll call the other half of the story. And that's the crura of the diaphragm, or the crural sphincter in this disease. That really doesn't get the attention that the lower esophageal sphincter has. For decades, it's really just been all about the lower esophageal sphincter. And I would argue really that the crura over the decades has been sort of like that creepy uncle. Every family's got one. We all try to pretend like we don't have one. We don't really want to invite him to the holiday dinners, but we have to. We hope he doesn't come. So what I'm going to talk to you about today is really going to debunk the importance of the LES and talk mainly about the importance of the crura. I'm also going to talk about a little bit about what's leading to what I call an epidemic rise in the incidence of Barrett's as well as esophageal cancer here in the United States. And at the very end, go through a little bit of our options on how to stop this epidemic. So for 20 plus years, and I would argue probably 50 years, the conversation around reflux has all been centered on the lower esophageal sphincter. My mentor, Tom DeMeester, was the king of that. He made his entire career out of this little 1-inch area called the lower esophageal sphincter. That was the root of all the evil in regards to reflux. Nobody talked about anything else. What that led to was us focusing on trying to come up with better techniques to fix the lower esophageal sphincter. Nowadays, we've probably got 10 different ways to fix the lower esophageal sphincter and are still working on other ways that somehow are going to be better than the procedures that we already have. So anti-reflux surgery forever has been about fixing the lower esophageal sphincter. But again, I'm here to tell you the crura are just as important and maybe more important than the lower esophageal sphincter. This right here is a publication out of the Cornell group out of New York, who did, to me, a fascinating study where they looked at what constituted that reconstructed barrier when we do surgery. Meaning when you go in there to fix a hiatal hernia and do a Nissen fundoplication or a toupee or a lynx, what is contributing most to that newly reconstructed barrier? And so what they did is they took 100 patients, they went in, did hiatal hernia repair, and either did a Nissen, a Toupet, or a Lynx. They did endoflip at different points of the procedure to tease out the contribution of each, meaning the hiatal hernia repair versus the LES repair, to the contribution to that new barrier. They mainly looked at distensibility index to look at the change in compliance of the tissue in that area. And what they found surprisingly was that the repair of the hiatal hernia constituted about 80% of that newly reconstructed barrier. I think before this publication, many would have said, well, I'm sure it's at least 50% the lower esophageal sphincter, or maybe even as high as 80%. They went further to look at the difference between Nissen, Toupet, and Lynx. And what they found was that there really wasn't any difference. Each of these procedures were good, and each of these procedures contributed about the same amount to that newly reconstructed barrier. And so at the end of the day, what they concluded, as many have, is that repair of the hernia was 80% of that anti-reflux procedure, and repair of the lower esophageal sphincter was only about 20%. Now, despite this fetish that we've had over these last 30 years, if not more, this LES fetish, as I will call it, has created an island of misfit toys. Like I said, at the very beginning of this, our focus has always been on trying to come up with better techniques to fix the lower esophageal sphincter. And somehow we continue to believe that fixing only the lower esophageal sphincter will solve the world's problems here. Well, up on the screen right now, you can see these are many things that have come and gone because they didn't work. They didn't work if you only fixed the lower esophageal sphincter. It's only part of the problem with this disease. And I will tell you that a live demonstration of this has been our experience with TIF, the transoral incisionless fundoplication, if you're not familiar with it. You know, TIF actually creates a very good LES repair. It creates a very good partial fundoplication. But in and of itself, only fixing the lower esophageal sphincter, as I said before, is not going to cure the problem. And so if you've been following along here, if you only fix the lower esophageal sphincter, meaning if you only do a TIF and you don't fix the hernia, pH normalization rates have been shown to be only about 40%, which I don't think anybody on this webinar would argue is a good thing. Now, if you instead combine a hiatal hernia repair with a TIF, now all of a sudden you get to 90% pH normalization. So again, illustrating the importance of fixing both of these problems if we want to reconstruct that barrier to prevent reflux. But again, I think by focusing only on the lower esophageal sphincters, we have lost sight of the importance of the hiatal hernia, as well as how to decrease the recurrence of the hiatal hernia. And I'm sort of cutting to the chase and getting ahead of myself here, but as you will see here shortly, you know, the recurrence rate of anti-reflux procedures isn't because our LES repairs fail, it's because our hiatal hernias come back. And this struggle is real. You know, anti-reflux surgery generally fails, even in the best of hands, at about 30% at 5 to 10 years. This is just one such publication that looked at the failure rate of Nissen fundoplication over time. And what they found is this procedure, the Nissen fundoplication, was great out of the gate. I mean, success rate was over 90% at stop and reflux. But by the time you got out to 10 years, the failure rate was upwards of 30%. Attila Sendes from Chile also published his recent data where he looked at 150 patients out 10 to 15 years and found very similar findings. The failure rate was almost 30%. And the reason for these failures, everybody thinks, is because somehow the fundoplication spontaneously came undone. You'll hear it all the time, surgeons talking about, well, you know, the wrap is disrupted. It's not working anymore. Somehow the wrap has spontaneously come apart and reattached itself to the spleen. Well, I'm here to tell you that that's not the case. This publication looked at that very question: what's failing in anti-reflux surgery? So they took 284 some odd patients and they took them back to the OR to fix their recurrent reflux after Nissen fundoplication. And they specifically want to identify whether or not it was failure of the fundoplication, meaning is it disrupted? Did it come apart? Or is there a recurrence of the hernia? And what they found was over 85% of the time, in fact, almost 86% of the time, the failures were due to recurrence of the hiatal hernia. The Nissen itself seems to be durable. And in fact, I will tell you that most of our LES repairs, quote unquote, are durable. That's not what's failing. What's failing is the hiatal hernia repair. Now, as everyone will know, and I can speak firsthand for this, the first step of a 12-step program is admitting you have a problem. And so I admit we have a problem. We have a problem with recurrence of the hiatal hernias. But our answer over the year as surgeons has been, well, we just need to slap a piece of mesh on there and that'll solve the world's problems also. Well, there's really no data to support that, at least in the long term. Mesh has never been shown to decrease the recurrence rate of our hiatal hernias long term. In fact, this is the most recent study, a randomized controlled trial just published in 2023 that looked at the use of mesh versus suture repair. Did it make any difference? And what they found is identical to what every other trial has found. It didn't make any difference. Mesh wasn't our answer. It did not fix our recurrent hiatal hernia rate and recurrent GERD rate. And so I don't have all the answers here, but I can tell you this. Mesh doesn't seem to be the answer. It does not seem to be the solution to our problem. Now, maybe, and just maybe, platelet-rich plasma might be an answer. I will tell you right now, in medicine, no matter where you look, platelet-rich plasma is all the rage. Everybody's into it. Orthopedics is injecting platelet-rich plasma into joints to try to fix tennis elbow and arthritis, as well as plantar fasciitis and many other things. Cosmetologists, dermatologists are using it to inject into the face because what it results in is increased collagen deposition, which sort of tightens up your skin. Hence why I look younger than my stated age. It's used for hair restoration. People that are going bald, platelet-rich plasma seems to increase hair growth for them. Again, why I've got most of my hair left. And it's being used in many other areas of medicine to improve wound healing. And so this possibly, maybe, will be our answer to this very high recurrent GERD rate after anti-reflux surgery. Because at the end of the day, reflux and hiatal hernias tends to be or seems to be a connective tissue disorder. This is a publication that came out looking at platelet-rich plasma used to fix hiatal hernia repairs in a pig model. Or actually, no, in a human model. Prior to this, we had pig models. So this group of surgeons out of the Ukraine got together and decided, well, let's try it. Let's see if we can inject platelet-rich plasma into the crura of the diaphragm at the time of hiatal hernia repair. So they did it in two phases. The first phase was a cadaver model where they injected it and looked at the cadavers. And what they found was that the cadavers definitely had, with hiatal hernias, had a lower content of type 1 and type 3 collagen. They then went into the human trials where they injected it at the time of hiatal hernia repair. And what they found, now they didn't have a control group, but what they found was that if you injected platelet-rich plasma into the crura to increase wound healing at the time of hiatal hernia repair, the recurrence rate seemed to be lower than the traditional recurrence rate that we see. And in fact, what they saw was a recurrence rate only of about 3% or almost 4% at 4 years after the procedure. If you look at Nissen data, that recurrence rate will be upwards of 25% at 4 years after an operation. So seemingly making a difference in decreasing that recurrence rate. Now, we at USC, our group launched a randomized controlled trial, a human randomized controlled trial, looking at the use of platelet-rich plasma at the time of hiatal hernia repair and LES repair. Now, these are preliminary results. We don't have the trial completely enrolled, but it is a registered randomized controlled trial comparing PRP to no PRP, meaning just standard suture repair. All patients in this trial had to be bigger hernias, meaning greater than 5 centimeters. All patients got a partial fundoplication. The goal here was 150 patients total, 75 in each arm. We currently have it to probably about 60, 70% enrolled, but at least initially the preliminary results are showing that the recurrence rate in the PRP arm seems to be significantly lower. So stay tuned. We should have it finally finished enrolling by the end of the year. So anyway, why is this important? Well, I think it hopefully illustrates to you that GERD is a mechanical problem. GERD is what's leading to Barrett's. The barrier to reflux is both the combination of the LES as well as the cura. GERD is a failure of that barrier. And GERD is what's leading, obviously, to Barrett's and this rise we see in esophageal cancer. Like I said, this is at an epidemic rise in Barrett's and esophageal cancer. In fact, this was from an abstract that presented a couple of years ago. That blue dotted line that's headed this direction like that is adenocarcinoma of the esophagus here in the United States. We've seen just an astronomical increase in this cancer in the last 30 to 40 years. To me, like I said, epidemic proportions. Now, how do we stop this epidemic? Well, Shree's going to talk to you here in a minute about early detection. He's going to talk to you about eradication. And these are definite steps that we can take now to try to make a difference. But in the most simplistic view of this, I would argue, why don't we just fix the underlying problem? Again, if GERD is a mechanical problem, let's fix the mechanical problem and get rid of the GERD. Maybe this will impact this epidemic. Now, fundoplication has been used to try to do this. And like I showed you earlier, the reflux control, at least for the first few years, is excellent. But I will tell you, when we use it for Barrett's or in a patient that's getting eradication of Barrett's, the recurrence rate of the Barrett's is upwards of 10 to 30%. And the reason it's that high is because, well, you still got ongoing reflux unless you were one of those that got a fundoplication. And in fact, Shree's group put together this publication, which I'm sure he'll talk about, looking at reflux control being important in not only eradicating Barrett's, but decreasing that recurrence rate. So in Shree's study, they made sure that the patient had good reflux control. 40-some patients went ahead and got a Nissen fundoplication to provide that reflux control. And by doing that, by providing better reflux control, he dropped the recurrence rate of Barrett's down to about 4.8%. So again, illustrating the importance of controlling reflux in a patient with Barrett's, and especially in a patient with Barrett's that we're trying to eradicate the Barrett's. The downside here is fundoplication has gotten a bad reputation. I can tell you most of our patients has already consulted with Dr. Google, and none of them want a fundoplication. They've heard the horror stories, the gas, the bloat, the this, the that. And it's hard to talk a patient into having a fundoplication these days. And so that brings us to the question, well, what about links? Links is this little magnetic bracelet made up of little magnetic beads that we place around the LES. Force of attraction of the magnets coming together keeps the lower esophageal sphincter closed to prevent reflux, but the force of swallowing or belching will cause the beads to spread apart, so patients can do that normally. It's been shown in numerous studies, including a randomized controlled trial and some prospective registry studies, to be equal in efficacy to fundoplication. It's been shown in numerous studies to have less side effects, including less gas and bloat, and an increased ability to belch and vomit. It's also been shown to be durable. This is a publication from Luigi Bonavina out of Italy, who looked at a series of 150 some odd patients that were out beyond 6 years. In fact, mean follow-up in this study was about 9 years. And what he showed was the procedure was durable. 80% of patients still at 9 years had excellent reflux control. They were off their PPIs, and their pH parameters were all normal. Now, what's huge in this disease is links. When it was originally approved, the FDA had a precaution listed for its use in patients with Barrett's because there just really wasn't enough data. But earlier this year, the FDA lifted that precaution, so Barrett's is no longer a precaution for a patient that's being considered for LINX. And the reason they lifted it was based on a number of different publications. Many of them were from our group, where we looked at patients with Barrett's and the use of LINX. This was our initial publication dating back to 2018. We looked at 67 patients. We broke it down into short segment, ultra short, and long segment. And what we found is that it worked. It worked equally as well. pH normalization rates were 85, 90%. Demeester scores went from 35 down to 9. We also looked at Barrett's regression, and this is where we were a little bit surprised. If you look at Nissen literature, regression rates after a Nissen in short segment Barrett's is somewhere around 30 to 40%. But what we were seeing here in short segment Barrett's is the regression rate was almost or over 70%, which seemed way too high. But even when we looked at patients that had had multiple follow-up endoscopies, the regression rate was still hanging around 70%. So since we didn't really believe that, we then looked at another cohort of patients, another 87 patients that we had done with LINX that had Barrett's esophagus, again, broke it down into short, ultra short, and long segment. Again, 85% pH normalization. Demeester score is down from 34 to 13.7. And again, a regression rate in short segment Barrett's of around 60-some%. So I can't explain why it's so high compared to the regression rate with Nissen fundoplication. But at the end of the day, the point here is that LINX is an option in patients with Barrett's. It does seem to control the reflux, and most importantly, the FDA has listed that precaution. Also in our study, we have not seen in either cohort of patients any progression to dysplasia or cancer, and we've also shown that ablation can be done with a patient that has LINX. There's no contraindication there. So I've used up all my time, so I'm just going to kind of summarize things real quick. The GERD barrier, I just want to stress this, is both the crura and the lower esophageal sphincter both need to be addressed if we want to stop reflux. Failure of the barrier is what's leading to reflux, obviously, as well as Barrett's and esophageal cancer. And it's crazy to me that we just keep doing the same thing over and over and ignoring this epidemic. LINX is definitely an alternative to fundoplication. I would argue a great alternative that has a much better side effect profile. And like I said, the FDA has lifted the precaution in regards to its use in Barrett's. So my recommendation is we want to impact this disease, impact Barrett's, impact esophageal cancer. We need to start thinking about fixing the mechanical issues. So with that being said, Sri, I've babbled long enough, and I am going to turn it over to you.
Fantastic. Thank you. And that was John. Personally, I can't take credit for him being me, although I'd like to sometimes. So that was great. And I think this is a great segue into my spot. And just as a quick reminder, so my name is Komanduri. I'm an advanced endoscopist, not a surgeon. But you're going to find a lot of common paths in what we just heard tie together what I'm going to talk about. And trying to be super succinct, I want to bring us together on where we stand as we take the next steps of the continuum around Barrett's, the novel innovation around screening, surveillance techniques, and also endoscopic eradication. And in the end of this, I think we're going to end up right back where we started, and that's in the reflux arena and what causes this and why and how this plays such an important role. So I'm going to share my screen and quickly convert over here, and hopefully this looks good. All right, perfect. That looks all right to you, John?
Looks great. Perfect.
So these are my disclosures. And as I sort of kick this off, just playing this video on the side, which is sort of one of many stories that our patients have with Barrett's, and you'll pick up on certain things about this video. But as we talk about the continuum from reflux to cancer, there's a lot to unpack in every segment. And as we do an endoscopy, I'm going to spend some time really focusing, excuse me, on what we call a high quality exam. And what you're seeing here, sorry for that, is a video sort of depicting some of the questions on the right. So when you're doing an endoscopy, and this is slowed down at the speed that we'd like to say that we're all scoping at, what exactly are we looking at? What steps are critical for endoscopic surveillance? And what is that true high quality exam? How did my patient get here? And John talked really nicely about the reflux component. And we're going to really spend some time highlighting that continuum. Could we have detected this sooner? So what we're learning now is we're probably not finding enough patients with Barrett's. We're really good at treating Barrett's, but we're really just not finding the patients to offer endoscopic eradication, which we're very good at. How do I sample this? And clearly you're seeing a nice visible lesion here on the video under narrowband imaging. Whether this is super advanced or early, more to come on that, right? And so many of us could debate how would we approach this endoscopically, EMR, ESD, multimodality therapy, or even esophagectomy down the line pending staging. Ultimately, my patients will ask, what is my long-term outcome? So where are we in this continuum in treating this disease? Because we know the end stage of this still remains very poor. So I put this slide, and again, this was highlighted by John, and I think it's critical for us as gastroenterologists on this meeting to really think about this. So when you see a patient at any step of this, so we all see patients with reflux, Barrett's-related neoplasia, and esophageal cancer. And yes, they're all a part of the same continuum. But if you're seeing a patient with Barrett's, it's critical to understand where that leads in terms of esophageal cancer. If we're seeing a patient with Barrett's or Barrett's-related neoplasia, it's critical to address their reflux burden. And this goes beyond a very simplistic, hey, are we taking our PPI? Yes or no, and moving on. A lot of this is nuanced, and we know the vast majority of reflux disease in this cohort is asymptomatic. And I think that's one of the key takeaways as we get into risk stratification, understanding where our patients lie, is to keep in mind that many of our patients fall into two buckets. The first bucket is my symptoms of heartburn and reflux are not real. I don't need to see a physician. That's wimpy of me to do so, and that's something I pop a few Tums and I feel better. Or they have silent reflux, which a lot of our patients do, and that's why they don't show up in our clinics or in our endoscopy suites until they have dysphagia and have severe esophagitis or even more horribly have esophageal adenocarcinoma. So this is a little bit of a bottom line story, and it's a little depressing for some of us. So if you look here, this is the trends in incidence of esophageal cancer, and this is from the NCI in 2022, with some key points. And the top line here is sort of that male component of incidence of esophageal adenocarcinoma, and the bottom is the female. And I threw in some key points. We started performing endoscopic eradication therapy with ablation back in 2005. And then here's where high definition narrowband imaging came into play, ultra high definition scopes, and ultimately AI, which we'll touch on briefly. But really what you notice is very little change in the incidence. So all these lives we're treating with RFA and EMR and ESD and PDT and hybrid APC, we're not really making an impact. And so that depressing part of the story, even though we're fantastic at achieving complete eradication, is we've created a situation where our abilities to treat the disease far surpass our ability to diagnose it. And if you take a minute just to think about that, that doesn't apply to a lot of states that we see on a day-to-day basis. So we got to figure out how to find this disease. One of the key pieces for us as gastroenterologists is really about innovation. As we head into 2025, there is a lot of change happening in screening, surveillance, early detection, risk stratification, from non-endoscopic screening tools, as you see up here, to things, sponge-based, catheter-based technologies, transnasal endoscopy, which we perform routinely at Northwestern in the new single-use form, is very productive for early detection. We also have things like the Watts 3D brush technology. We have risk stratification with TissueCypher or tissue systems pathology, and I'm going to walk through that. All of this is very exciting because what it's doing is taking some of the gaps and creating an algorithm for us to follow that has a much more higher degree of accuracy. So when we walk through this paradigm, this is what you do. This is what I do. We walk through this day to day. We walk through this for 50 years, right? Screening to some degree for high-risk reflux patients. We'll touch on how that is changing and evolving. Use of optical imaging of high-definition white light, narrowband imaging, and all the way through our standards, which have been part of the guidelines. And frankly, they're part of the guidelines that are coming out in 2024, and nothing has changed. And we're going to talk about the impact of where we are finding significant issues because of our inability to perform most of these steps well. So when you look at high definition white light, that's absolutely the bare bones minimum, right? We know that narrowband imaging or some sort of optical chromoendoscopy, like BLI, depending on the type of endoscope you use, is critical. It's not only critical, it's medical legal in the US, a part of our guidelines and something you must do and document in every endoscopic exam. And unfortunately, this is not something we see all the time, and even at the highest level of institutions. What is a visible lesion, right? This goes much further than the typical, hey, I have a mass, I have a nodule, I have an ulcer. So the use of NBI or BLI lets you identify early vascular mucosal patterns that are very typical for neoplasia. One of the biggest issues we will run into, and one of the takeaways from this talk, is really about interval cancer development, or what we call post-endoscopy esophageal neoplasia or cancer or PEAK, which has become one of our significant metrics in the field to avoid, very similar to interval cancers in the colon that we're trying to avoid, but it's a real thing. So these are patients who develop neoplasia or cancer in the interval in which you said, hey, it's safe for you to not be scoped. So for many patients, that's the 3 to 5 year window. Seattle protocol sampling. So does it really make sense? Can you, as a patient, have your doctor tell you that I'm going to sample 25% of the surface area at best with these random biopsies and tell you your diagnosis? To me, that seems foolish, always has, but we tell that to our patients. In fact, Seattle protocol sampling is not only our guideline-driven statement, it's a quality metric in Barrett's esophagus. And as you can imagine, that doesn't sit well with a lot of patients. And what we're finding as we introduce technologies like Watts and we start sampling the entire surface area, we're augmenting our neoplasia and dysplasia detection. We will overcome intra-observer variability, whether that's the use of technologies like Watts, but also with artificial intelligence. And we have companies that are coming out with that. It's still in investigational phases for the upper GI. Many of you might use GI Genius or analogous devices in the colon, but that type of sort of detection-based AI and computer or CAD-E and CAD-X type systems are coming out for the upper GI tract. But even once we diagnose them, how confident are we? Can we risk stratify patients? What's going to happen as we get into the new realm of non-invasive screening is we're going to increase this pool of non-dysplastic Barrett's, and it's going to become very important that we understand risk better. And that's where some of the tools like the tissue systems pathology, which we'll touch on, really help us understand not only driving patients to be eradicated, but also looking at patients who may not need continued surveillance, whose 5-year risk scores are very low. So this might be how it looks in the near future. We have office-based screening with things like transnasal endoscopy, things like sponge or catheter-based testing in the office. We do an ultra-high definition EGD with AI, CAD-E and CAD-X, tells us where our visible lesions are. We sample those visible lesions. We use AI-driven sampling with technologies like Watts. We have immediate pathologic interpretation from artificial intelligence that make our accurate diagnosis, offer them endoscopic eradication therapy. For our non-dysplastic patients, we perform tissue systems pathology and look at the mutational load and risk stratify and give our patients a 5-year report card for risk, and then decide on surveillance therapy in those patients or even cessation of surveillance. So we talked about this idea that we just can't find the patients, and this is that one of the studies that's quoted often, and the simple picture here is the pie. And what this means is that 7% in this study, but also up to 10% at max, this represents the proportion of patients who present to a surgeon with esophageal adenocarcinoma who've never had a diagnosis of Barrett's esophagus in the blue, right? So 93% of patients didn't have a precedent diagnosis of Barrett's, but ended up developing esophageal adenocarcinoma. So what does that mean? So that really tells us that the vast majority of patients aren't going to their doctors with reflux, or they just don't have symptomatic reflux. And that's where we're going to really talk about some of the changes in screening and some of the changes in the guidelines, which have found that for the longest time, our guidelines have pushed the concept of prerequisite of having gastroesophageal reflux symptoms for endoscopy. And that's something that we changed in 2022 with the AGA clinical practice update that now places reflux as just another risk factor. We all know and we've identified that risk factors such as obesity have a significantly higher odds ratio than true symptomatic reflux, even though symptomatic reflux can be a major symptom, and even though reflux is an absolute necessity to get to the Barrett's pathway. So what we really need to do is really focus a little bit differently on who we are bringing into our offices or to our sort of laboratory testing where we're offering minimally invasive testing for screening. And we're going to touch a little bit on what that looks like. So I'm going to just show you a couple of videos from technologies. These are not everything. And again, I don't have any tie to these, but these are just to give you an idea of some of how this looks from an animation. This is the EsoCheck EsoGuard device, and you can just see it going down. I've done this myself, and these are very easy to do in the office. This one takes about 5 minutes. It's something you can look at even in an admitting or recovery area to screen patients or in the clinic. And as you can see here, this goes down, the patient swallows it like a capsule. You drink a lot of water as it gets across the lower esophageal sphincter into the stomach. This catheter, as you'll see here, is then insufflated, and this very soft, but it's got these bristles or brush type circular areas that we're going to, as you pull back through that tension of the lower esophageal sphincter, and you'll pull back for a certain distance, you acquire the cells, and this is how once you've done that, I'm just going to move it along. This gets decompressed from the syringe, comes back in for a safe removal, and it comes out of the mouth very easily. It doesn't hurt the patient as it does so. So this is a great way, and this has been our most validated version of a non-invasive screening tool, which we are using in practice today. The key thing is to understand where and how and who to use this on, and we can go over that in the Q&A a little bit. The bottom right you're going to see here is what the new single-use transnasal endoscope looks like here, and this is just a performance of this, and I fast forward on the model. And as you can see here, this is a very thin caliber transnasal endoscope. We are doing this in our office. And in fact, we are launching a study right now, and we've established a curriculum to train advanced practice providers in our clinic at Northwestern to perform this transnasal endoscopy. Again, when we start looking at these non-invasive modalities, these are not things we are going to be able to all take on as physicians. It's just too voluminous. So this has to be done by technicians, has to be done by advanced practice providers. And this is a great way to advance your APPs in something that there is precedent. They do this already, and they're credentialed well in our ENT colleagues' office. If you've ever had a laryngoscopy, a lot of times it's performed by advanced practice provider. But the key is the training and understanding the anatomy and performance in a safe way, and vetting their ability to identify and triage patients who might need sedated endoscopy. This is not meant to take away from what we do well. I'm going to move on for the sake of time here. And so this is the concept of the post-endoscopy esophageal neoplasia I talked about, up to 14%. We looked at this in the Northwestern healthcare system, and the bottom line is this is a real entity. So this is interval development of cancer and neoplasia. And what are the reasons for this is really around the high quality exam, and I'm going to walk through that in a second, but we have to, in the patients who perform endoscopic surveillance, eliminate some of the shortcomings that we can in terms of sampling, lesion identification. It's just about time and what we spend in the esophagus, but this is critical because you can't have an interval cancer develop in this disease. So what is that high quality exam we keep talking about? Most of this seems intuitive to you, but it's not always done, right? So just even the steps that Dr. Lipham went through on landmark identification, and why is that important? So what if you don't identify the DI or the top of the gastric bulge, because that means you're not really understanding the impact of reflux on this patient. And you may not be treating the patient effectively or correcting the mechanical barrier, which I also will heavily enforce, is by and part the most important physiologic issue in these patients. So then as you go down this list, things like distal attachment cap, as you saw in that first video, these are things to improve dysplasia detection, mucosal cleaning. Do you really spend a minute of time in investigating every segment of disease? Narrowband imaging, using the PROG classification, again, understanding when there's esophagitis, that sampling is not accurate. And that's something we see all the time. And then our use of CIO protocol, at least for now, as we understand more about Watts and AI-driven sampling. This is the Watts brush technology. And again, I can spend a lot of time, but many of you are familiar and use this in your practice, but this demonstrates that ability of that brush to kind of be circularly passed and advanced here. We are in the midst of a large multi-center Watts versus CIO protocol trial. Already we've demonstrated the increased yield of the Watts technology, but that's something to look forward to. The tissue systems pathology or TissueCypher, which again is a way to look at this mutational load and provide a 5-year probability score. We use this routinely for some of our high-risk non-dysplastic patients. And this allows us, and this is a recent paper that came out in Clinical and Translational Gastro, to look at actually the clinical practice model. How does this affect patients when you are specifically looking at physician compliance with existing guidelines? So if you notice here, patients who had TissueCypher adopters as their physicians really improve their skill set at assessing risk of progression properly in concordance with guidelines, when to recommend endoscopic therapy, and when and properly performing the right surveillance interval. So this is something that is here to stay and something that's very critical for our practice moving forward. So when we talk about screening, again, this is a key piece from the CPU update in 2022 that we wrote, is including chronic reflux as just another risk factor. And so now with patients with at least 3 established risk factors, we may consider screening. So this is not necessarily only looking at every white male over 50, but it's taking that basic set of criteria and then looking at other things like obesity, smoking, GERD as another symptom, but not having the prerequisite of reflux to do a screening modality. So non-endoscopic cell collection devices, the EsoGuard, which I talked about and showed you, most recently a study in the Red Journal showing a sensitivity and specificity of 85% in all cancers detected by this technique. Watts 3D, most recently, like I talked about, looked at the adjunctive yield of 76%, but most importantly, the absolute yield of neoplasia detection of 18%. So 240 patients in the study with dysplasia were found by Watts only and not by biopsy, so you can see the direct impact, but more data to come on this. And lastly, like we talked about, tissue systems pathology or TissueCypher is a great risk stratification tool and really does help us adhere to clinical guidelines and improve patient outcomes. These are a sort of a summation of our novel innovation in 2025 for screening, surveillance, and risk stratification. And we can spend some time in the discussion kind of walking over some of these a little bit more. But what it really should impart that you as a gastroenterologist, if you are not finding your practice falling into place in some of these, this is where you need to start to head. And as we start to do this, you're going to see more patients, similar to the Cologuard era, showing up to your door with Barrett's esophagus, and you need to understand how to sample them better, perform a high-quality exam, screen the proper patients, understand the impact of obesity over reflux, and then risk stratify non-dysplastic patients. And we have the innovation to do so now. So lastly, just a touch on where we stand with endoscopic eradication therapy. So as we identify the visible lesions and we go between EMR, ESD, surgery, all the way through our ablative strategies, we know combined modality therapy with resection and ablation, whether that's RFA, cryotherapy, is the key here. We know that we can achieve a 90% complete eradication rate, and recurrence is less than 3% of dysplasia, IM and 10%. And when reflux, again, is really controlled, you drop this even further. There's a new, just hot off the presses, the 2024 AGA endoscopic eradication guideline. Again, supports therapy for high-grade and low-grade dysplasia. Still, the word is out on non-dysplastic Barrett's, but that's where TissueCypher really helps. EMR over ESD, and that's kind of where we actually stand in 2024 in the US. Really, we reserve ESD for high suspicion for a T1B lesion or really bulky disease. And it's critical when we have patients that are refractory to EET to consider the mechanical barrier, and that's the work that we had performed, which I'll touch on in the final slides here. This is a little bit of a flow diagram. I'm not going to spend time on it today, but reason I put this up, this is our work at Northwestern, all the way from our patients enrolled in the last 10 years through our recurrence rates over the last 3 to 5 to 10 years. And the bottom line here is if you are going to perform endoscopic therapy is to track your data. And this is just a symbol of that and why it's critical so you understand and see the story that you've created all the way from who you're treating, why you're treating, how durable is this, and are there adverse events that I need to be considered, and what is the quality of the work I'm doing. So one of the guideline recommendations from the AGA is that anyone taking on endoscopic therapy should be tracking their outcomes. So where's the summary on the therapy piece? As we said, EMR is the preferred resection strategy. Further data in regards to ESD training and innovation is needed. Ablative strategies, RFA remains the ablative strategy of choice with the highest rates of complete eradication. However, cryotherapy, whether that's with liquid nitrogen and balloon ablation, has been extremely effective at esophageal cancer palliation and something you should consider if you have patients with dysphagia, much better than radiation in my mind or stent placement, especially in patients you're just palliating. There are more data coming forth around both liquid nitrogen cryo and cryoballoon for primary modality therapy in Barrett's associated neoplasia, but still RFA remains the treatment of choice. And we do need a lot more data on hybrid APC. The advantage here is no capital expense, and the advantage of cryotherapy is there's no pain compared to RFA, which I find very beneficial. But again, the data speaks right now. And so all of these should be in your toolbox if you're performing therapy to offer when one of them may just not work. The last slide here is really around PPI compliance. Last couple of slides, sorry. And one of the biggest things that we found is that insurance companies and sometimes primary care physicians talk to their patients even after eradication, stop their PPI, switch them to H2 blockers. So you always want to be on top of your patients, make sure they are taking what you think they're taking, not just checking off your EHR medical. And this is just somebody who had a high-grade dysplasia in the setting of esophagitis and actually just took his PPI, and this was actually just non-dysplastic Barrett's, sampled a couple of times over again. So this is a big deal. So as was said, when patients who have refractory to endoscopic therapy or incomplete response, they generally have an uncontrolled reflux burden. And when we talk about reflux burden, we're talking about what John hit on, which is that mechanical barrier. It's not about sprinkling the PPI. When we use a very rigid reflux management protocol, and this is what we published in the Red Journal, and now includes over 100 patients with links and hybrid TIF procedures, which again is really addressing the components of the barrier that Dr. Lipham spoke to, that recurrence rate goes nearly to less than 4% and almost down to 1% at 10-year mark. And that's some data that you'll see come from our group as we've reached or eclipsed that 100 procedural anti-reflux procedural mark. And I think the key here is just to understand, most of these people have a very big barrier, a very open barrier, patulous G junction, have very poor reflux valves, and have large hernias, right? So this is not rocket science. Your patients understand it. The contents of the stomach go up and down. Acid is just one component of that. And the only way to really prevent this disease from coming back is closing that door, in my mind. And so ultimately, as I said here, we did this and we showed that the recurrence rate goes down with mechanical barrier control. And again, as you keep going, and actually, sorry, one of the last points, we did a study and presented DW last year. There was actually no difference in patients who achieve complete eradication when you start going up to double dose PPI or increase the frequency or change the drug. Again, it really points to this concept, which is patients who undergo EET for Barrett's neoplasia, mechanical barrier correction should be considered for uncontrolled reflux. And we offer it to all of our patients when we're said and done. This is a laundry list of our protocol at Northwestern that highlights everything I've spoke about. Again, it's just to show that you should have an algorithm, have a plan, how you approach patients, whether it's high risk stratification for screening, novel technologies like we've talked about today, inclusive of obesity management, smoking cessation, all the other aspects. all the way down to upper endoscopy, high quality exam, utilizing techniques like Watson, TissueCypher, and then optimizing therapy. This is a complete practice in and of itself, and you need the time. So lastly, it's time to think outside the box. While esophageal cancer is rare, the rising incidence is alarming. It's often silent. It's critical to look beyond reflux. It's not the greatest risk factor. We're talking obesity should be part of your practice and something we counsel on and something we are involved in from the front and look at as a risk factor for screening. Again, considering educating patients with at least 3 risk factors to see a gastroenterologist. Similar to colorectal cancer, patients should be screened without sedated endoscopy. We can do that well now. Adequate control of reflux is critical to reduce esophageal cancer. So that's critical. The new ability to perform links in patients with Barrett's, at least from an FDA standpoint, even though some of us may have been doing it, we won't say we will, but also the hybrid tip procedure. And both of these are correcting the same issue around the mechanical barrier. Think about that for your patients. We really want to reduce the incidence of post-endoscopy neoplasia. And then again, early detection, again, can be cured endoscopically. This is my last slide in every one of my Barrett's talks for the last 15 years, and it gets more and more true. So what if I told you we'll soon live in a world where all patients will be screened for Barrett's in their primary care's office using an inexpensive in-office device, started on PPI therapy and referred to a GI positive. Patients will undergo high-quality endoscopy and treated if there's evidence of Barrett's. Upon completion of this, they will undergo biopsy to confirm a cure, and then a surgical or endoscopic anti-reflux procedure shortly thereafter. Will stop their acid medication, recommend yearly non-invasive surveillance by their PCP for 3 to 5 years. You'll give your patient a hug, wish them a great life, and part ways knowing we finally cured esophageal cancer. Thank you. So I welcome my surgical friend, and if you noticed, we took very different angles at very different, sort of a similar continuum, and we ended up at the exact door together. And it's pretty amazing how much of this continuum is caused by reflux and is mechanical reflux, and lots to do for us as gastroenterologists. It's a pretty exciting time to be a Barrett's person or Barrettologist. Whether that's, if you really look at that continuum and you look at the reflux, the impact of obesity, where does endobariatrics fit in, where does gastric sleeves fit in, you could run your entire practice off of what we've talked about tonight, but you end up back at reflux. And I think we can't emphasize it more, how critical it is to control that barrier. John, any comments? And then we'll break into these questions.
No, Sri, fantastic talk. And I agree. I mean, I think we all land on the same place about, controlling reflux in some way to impact this disease. But we want to get right to the questions. The first one I think is in your wheelhouse, and I can
Sure.
kind of read it to you. It's about TissueCypher. And the question reads, TissueCypher reminds me of Pancreagen for pancreatic cysts in terms of molecular diagnosis for stratification, risk stratification. How can you be sure of its impact for risk stratification, considering it's such a new technology to assess this? How confident basically are you in the data and its ability?
Yeah, and I can speak personally to it. I chaired the Center for GI Innovation for the AGA, and one of our offerings was working with companies on designing their pivotal trials. Back when TissueCypher was with Cernostics, they came to us, which was a great, thoughtful way of how to do this. And about almost 10 years ago, we put together a panel and we counseled them on how to design the 5 studies which they've published over the last 10 years. And those pivotal trials were designed in such a way with pathologists, GI experts, and Barrettologists, clinical trial experts, to do it the right way, not necessarily a randomized controlled trial, but the proper trials that demonstrated, if you look at the data, not only efficacy, but looking at the different populations of indefinite for dysplasia, low-grade dysplasia, also temporospatial analysis. So if I take a biopsy from multiple places, does it give me the same result? And what is that over a timeline of durability? Yes, we don't have 20 years of it, but right now it looks extremely effective, and especially for the negative predictive value, to stop surveillance on patients, it's absolutely ready for prime time, and that's why you're seeing it in guidelines now.
Fantastic. I think the second question is also more in your wheelhouse than mine, but it is a question I had also. And the question comes from Dan Lister, who's a good friend. but I've thought the same thing in regards to using the Watts brush. You know, if you look, nobody does the Seattle protocol well, if they do it at all. Are we getting to a point where maybe we just do targeted biopsies or EMR for nodular stuff and then Watts only? Do you think we'll ever be that point and eliminate quote unquote biopsies, random biopsies per Seattle protocol?
Yeah, and that's really the component of it's called the SWAT BE study right now that's going on, comparing both arms. And I'm not going to say that I love the Watts technology. It's the idea of covering the entire surface area. There's still some technical sides to it to ensure you get proper cellularity. But yeah, absolutely. I think we have to factor in surface area. Where does resection fit in? But also, where is our AI and our CADX and CADE sort of systems going to evolve, and how much of that is it going to be a lesser concern of missing neoplasia? But I think we are going to evolve away from just random biopsies for sure. I do see a question here that I can ask you, John. I think we talked a lot about the efficacy and the data with links. You talked about there's a question about CTIF over regular TIF, which you identified may not be optimal. But does CTIF offer an advantage over hernia repair plus a partial surgical wrap?
Yeah, I mean, it's a fantastic question. I can tell you, the company for TIF did recently finish enrolling a randomized controlled trial comparing not to partial wrap, but to Nissen fundoplication. So comparing CTIF to Nissen fundoplication. So that trial is just now finally fully enrolled, and now we'll have to wait for the data that's generated from it. Partial wraps were not included in that. And so the question of whether CTIF is any better than me doing a surgical hiatal hernia repair and a toupee or something, ultimately we don't know. I will say that TIF is more standardized in how it's done compared to how surgeons across the world do a partial fundoplication. We never really standardize things very well as surgeons, and so my toupee may look a lot different than somebody else's toupee. So TIF may have an advantage in the standardization aspect, but ultimately right now I don't think we know the answer to that question.
Yeah, and I think the great question here, the great piece is that we're talking about the barrier in all three of those. And I think everything, and this is where the surgeons can really help us, and as they advance. And I think we talk a lot about the gastroenterologist really understanding, and there's some good questions about that on here. And the same way, I think it is important for our surgical colleagues to advance themselves like Dr. Lipham has, and there is an advancement that's happened. We do need to correct more of these barriers, but there's newer ways to do it. And I think those are, not everyone needs a surgical fundoplication. The LINX is a great option, probably a better option for a lot of these patients. One of the things that's on here, which is, I think, really interesting, is a great question. I'll combine two of these, which one is about how do you foresee us handling the disease burden with all potential screening, but also why has esophageal cancer sort of fallen or just not raise the level of awareness? And I think John and I both work with ECAN. I've heard this before. I think I'll answer and then I'll let John answer. But I think part one, I think the awareness, when you have such a technically a low prevalence cancer compared to the others, it tends to sit in the back. But I think what we see in the last few years, because of the mortality of this disease and because of the rising incidence and the innovation we're talking about, that we might be able to make an impact, it is coming to a higher visual point. And this is best seen by the research funding that we're seeing coming through places like the NCI. I don't know if you have any comments on the awareness of the disease, John.
No, I would agree with you. I think part of it is because it has been, it was incredibly rare. Rarely, even my mentor, Tom DeMeester, rarely saw adenocarcinoma of the esophagus. But it is, like I showed you on that graph, it is taken off. And I think because of that increase in its, prevalence and incidence, I think we are getting a little bit more focus. And I think ECAN, which is a fantastic organization that is trying to raise awareness, has done that. And I think part of it's on ECAN for raising awareness. and we do have a lot more funding for research now. So, at the end of the day, it's good and bad to have media attention. If you have media attention, it means you've really got, I think, a high incidence like breast and colorectal. But we're getting there if we don't stop this. I mean, eventually we will be to the level of at least colorectal cancer.
A question about post EET esophageal stenosis. It's a good question. We see it more now. I see it more because I'm much more aggressive, but it's easy to manage. I think the key is not to react quickly in the first few weeks of patients having dysphagia, making sure they're following their diets, continuing to suppress their reflux with medication. And then when you need to, dilating them aggressively. These are patients who can tolerate it. And usually these are very responsive to a simple balloon dilation. So that's not a big issue on that part. The last thing I just want to say about the disease burden, I think this is the exciting question. We saw this happen with Cologuard in our practices, and people didn't believe in stool-based testing. And now is it not only so prevalent, it's a massive part of what we're going to see how we fix our colon cancer screening issue. But what you ran into is that your patients are coming and flooding your clinics with Cologuard positive tests, and you need to have blocks of endoscopy for this. Similarly, what are we going to do with all these EsoGuard and Cytosponge and sponge on a string and TNE that are going to find patients with non-dysplastic Barrett's? And that's critical because that's the problem of why we're not reducing that rate despite the endoscopic therapy. But we got to be ready for it. And that's why I think that it's critical for all of the gastroenterologists, as I can speak for them, to understand and use this innovation, but also understand the continuum we spoke about, because part and parcel to this still remains the question of reflux and what you do with this. You can treat the Barrett's, you can do everything you want, but you have to be super cognizant of mechanical reflux. John?
Yeah, no, I agree with you. Question here from one of my old fellows, research fellows, Colin Dunn, asked about when are the early PRP results going to be published? And this is a nice segue into promoting the American Foregut Society meeting, which is helping sponsor this webinar. We are going to present some of our data at the American Foregut Society meeting this year in Denver in late September. So I encourage you all to go, and you'll at least get a flavor of some of the early PRP results, which look fantastic so far.
And the only other question here is, what's the best PPI for Barrett's? Should I dare say it's Lynx? No. That was all in fun, guys. No panic here. No, but in reality, I'm being facetious, but you're hearing this from a gastroenterologist. You're probably used to hearing that. My messaging doesn't come from GI docs, but I can tell you it is the right messaging. And we as gastroenterologists have to shift our frame of mind. And my colleagues are we're very delayed in doing this. And when you have done and watched the continuum of Barrett's and the therapies we do, and with endoscopic therapy, you recreate the natural history and you see the patients come back with esophagitis. It's very evident, and that's how I learned it, that this is really ridiculous. This is not rocket science. It's what goes up, and what comes down causes this disease. And until you close the door, stuff keeps coming up. So I think it is an important point to this continuum, is to really understand that it's, we have so much innovation around this, but educating yourselves on that one component of the impact of mechanical reflux and the solutions we've talked about. We have so many good solutions now that are effective. They're not like traditional, legendary, old school fundoplication anymore.
I would agree. I'd like to drive that home. I mean, I think we're far better off with our treatments nowadays, procedural, whether it's CTIF or LINX or partial fundos, than we were, 30 years ago with Nissen fundoplication. I think that gave us a bad rap as far as controlling reflux, fixing the barrier. So in other words, don't believe Dr. Google necessary. The treatments we have now are far better off with much less of the side effects and issues that we had. So with that being said, I think that's all our questions that we have, unless somebody wants to throw one last one in there.
No, this was fantastic. And I want to thank you. We had a great crowd tonight. Thank you guys for showing up. Thank you to Endoscopy Now and the AFS for partnering and getting John and I together to tell very similar stories. And I think hopefully it rang true to you tonight. And exciting times. Let's go out there and treat some patients.
Hey, right. Love it. All right. Well, thank you,
Thank you
everybody.
guys. Have a great night.